போட்டீங்களா ஜூம்? ஆமா, மொபைலே எனக்குலாம் உட்கார்ந்து நின்று கேட்டதான் இருக்காது. நான் இன்னொரு கார்ல மாட்டிட்டானே. உங்க பீஜியா பார்த்த மாதிரி இருக்குது. என்ன டாபிக்? டாபிக் நீங்க இல்ல இவரு சொன்னார்ல, சென்னை சார் சொல்றாரு.
Good evening.
Good evening, sir.
Nice to see Jailal sir and Ajay Khanna sir, and Jailal has come from.
Sir, good evening, sir. Good evening.
Sir, we all are in Tuticorin.
Sir, good evening.
Good evening. Good evening, sir.
Oh, Srinivasan sir.
We are all in Tuticorin. Kanagavel is there with us. We are in Tuticorin, sir.
Oh. Cyclone prone area, no?
Sir? Tuticorin is near Tirunelveli, sir.
Cyclone prone area.
Cyclone prone area. I don't know, sir. Unda, in the cyclone, unda.
Sir.
Okay, sir.
Good evening, sir.
Good evening, friends. Sorry to disturb you, senior faculty here. It's 8 o'clock. And we have the honor of having invited faculty, Professor Pradeep Sharma, sir. We have Professor Antonio Rosario, and we are expecting Dr. Satoskar, sir, to join us shortly. And we have our senior faculty, Kanna, sir, Shanai, sir, Sandaria, sir, Karnakaran, sir, and others are expected to join. And I think Dr. Sahai has excused himself, so we'll have the faculty, other faculty to cover up for you. So we have two important presentations. One is from LG Hospital from Ahmedabad, kindly contributed by Professor Andaria. And the other presentation is from Dr. Srinivasan's unit, Coimbatore. The first case will be soft tissue tumor from Coimbatore Medical College. Dr. George will be presenting. And the second case will be presented by Dr. Pooja. It's a case of a varicose vein. So good luck to both of the candidates. The invited faculty, please take over. Can I request Dr. George to introduce yourself, your unit chief, your head of the department, and start your presentation. Good luck.
Yes, sir. Thank you, sir.
Make it full screen, Dr. George. Good luck to you, Dr. George. Please carry on.
Thank you, sir.
Start.
Can I start, sir? Good evening, respected faculties. My name is Dr. George. I am a final year surgery postgraduate from Coimbatore Medical College Hospital. My unit chief is Dr. S. Muthulakshmi Madam, and my HOD is Dr. Srinivasan, sir.
Dr. George.
George, we can't see your screen.
I think we have lost connectivity.
Okay, fine. That is the case. We'll give a minute or so.
Yes,
If
yes,
not,
sir.
we'll ask Dr. Pooja to start her presentation.
Good evening, sir. Kanagavel, sir. I am Dr. Pradeep Sharma. I have joined with name of Dr. Aditi Sharma. Probably.
Yes, sir. We have renamed you, sir. No problem, sir. I
Okay,
just saw
thank
the
you,
name
sir.
and I've corrected it. Now you will be
There
seen
was
as
problem
Pradeep
in my
Sharma
system.
only.
I downloaded my wife.
Yes, sir.
Thank you, sir. Thank you.
Give me 1 minute, sir.
Yeah.
George, are you okay?
Yes, sir. Hello.
Okay.
Am I
Good
audible,
luck.
sir?
Continue.
Sir, should I start from the beginning, sir?
Yeah, start from the first slide again.
Yeah, that is okay. Wait for a minute. I'm in PG clinic. And 10 o'clock.
George, are you okay?
Yes, sir. Some connectivity.
Please unshare your screen and restart.
Yes, sir.
I think his bandwidth is low. He can stop video and start slide share. Just
Yes, sir.
mute your video, then let us see. If it is okay, then we will add your video later on.
Okay, George, you please continue.
No. Yes, sir. The patient was apparently 3 months back when he noticed a swelling in the outer aspect of the left thigh. It was insidious in onset. It was initially small in size and gradually increased in size to attain the present size. There was no history of any pain over the swelling. There is no history of any discoloration or discharge from the swelling. No history of sudden increase in size of the swelling. No history of any trauma to the affected site. There is no history of any restriction of movement in the affected limb. No history of any weakness of the limb or tingling or numbness sensation in the limb. No history of any swelling over the distal limb or pain on exertion. No history of any recent swelling elsewhere in the body. No history of fever. No history of loss of weight or appetite. No history of cough, hemoptysis, breathlessness. No history of abdominal distension, jaundice. There is no history of any headache, vomiting, or seizures, and no history of any bone pain. Coming to past history, the patient is a known case of neurofibromatosis type 1 with multiple neurofibromas all over the body since young age. He is a known case of type 2 diabetes mellitus for the past 5 years and is on regular treatment with oral hypoglycemic agents. There is history of any radiation exposure in the past. Personal history, he is taking a mixed diet. His sleep and appetite are normal, above alcohol. Family history, his mother had a history of neurofibromatosis type 1, but there was no history of any cancer in the mother. There is no history of any similar swellings or malignancy in any other family members. To summarize my history, a 55-year-old gentleman who is a known case of neurofibromatosis type 1 presented with painless gradually progressive swelling over the outer aspect of left thigh for the past 3 months, which was not associated with any pain or any other symptoms. Shall I proceed to examination, sir?
Noma, you will be go back to the first slide. The faculty will be questioning you in the history part. Then only we move to the clinical part.
Okay,
Faculty, sir, please take over.
George,
sir.
can you hear me?
Yes, sir, I can hear you.
Yeah, just this is the swelling in the left thigh for 3 months, correct?
Yes, sir.
Now just next slide, please. Yeah, just very important point here is outer aspect to the left thigh. Thigh is a big region, so you should be a little more specific here.
Okay, sir. Middle 1/3 of the thigh, sir.
Is it upper thigh or lower thigh? You understand my question?
Yes, sir. It was middle 1/3 of the thigh, sir.
Okay. So outer aspect, it is very clear. So because we are not seeing any patient, no, here only we are only hearing. Okay. So insidious, small in size, gradually increased. At this stage, any other point you would like to ask? History of, you said insidious. Anything else? That, yes. Insidious onset. To start the onset, anything else?
Any history of trauma at the time of onset, sir?
Yes. Why trauma?
It may be a hematoma due to trauma, sir, or the trauma may have brought his attention to the already existing swelling, sir.
It's a whether it is there or not, it should be a practice. Examiners may ask you, it's an incidental, maybe attention, it will bring the attention. More importantly, skeletal system is vulnerable for trauma, hematoma, some organization into chronic abscess and all that thing can happen. Okay,
yeah,
right. Now gradually increase in size to attain the present size. I don't want you to say exact in size, but patient will tell sometime with their finger and thumb. So we need to understand what is that small. You can say, use the word approximately 1 to 2 centimeter. Everyone knows what is 1 to 2 centimeter. Why you would like to know this question? Small, and now we don't know the size. So what is the size now? Approximately.
Okay, sir. Around 10 to 12 centimeters.
So what does it tell you?
It
What
is
does
a rather
it-
big swelling, sir.
No, correct. What does it tell you? This kind of a growth of small to above 10 centimeter in 3 months. What does
It is
it mean?
rapidly growing swelling, sir.
So
So there is a chance of malignancy, sir.
chances of that, like for example, lymphoma, whatever the diagnosis is fairly straightforward here. It doesn't matter. This is how you should try to take on from him. I'm seeing Dr. Rosario here, sir. Please take over, sir.
We have Professor Satoskar joining us, sir. Good evening, Professor Satoskar, sir.
Yes,
Dr. George,
please,
Good
please
hear
take
me?
over, sir.
Please go ahead.
This is Dr. Rosario.
Please
Two
ask
things.
your question, sir.
Two things. One is you said there is no history of radiation. Why did you ask specifically history of radiation in this patient?
Because radiation is a known risk factor for development of soft tissue sarcoma, sir.
Okay. The second question is you said he's a known case of neurofibromatosis.
Yes, sir.
He's been, how old is he? You said 50 years, no?
55 years, sir.
Okay, so how is this swelling that he has now different from the swellings that he has had in the past of neurofibromatosis?
Our other swellings were noticed at the young age, sir, and they were small in size and almost remains of the same size, sir. They are not progressing, sir. But this swelling over the last 3 months, it has rapidly grown in size, sir.
So you need to tell the examiner that even though he's a case of he's a neurofibromatosis, he's had multiple swellings from many years, this particular is different from the ones that he has had in the past because it has progressively increased in size, because that gives you a different connotation.
Yes, sir.
Was the swelling there 3 months prior to 3 months and it has, in the last 3 months grown to this size?
Okay, sir.
Do you understand what the connotation is? It's completely
Yes, sir.
different.
Yes, sir. Yes, sir.
George, do you think that this swelling is related to the neurofibromatosis?
It can be related, sir. If already pre-existing swelling, it may now have increased in size, sir. But
So can you get a malignancy from neurofibromatosis?
yes, sir. There are neurofibromatosis. There is it can convert to malignant peripheral nerve sheath tumors. There is increased risk.
And which are the neurofibromatosis which are more likely to have the malignancy?
The plexiform neurofibroma, sir. Diffuse.
Good. Right. Now, do you think it is the neurofibromatosis type 1 or type 2?
Type 1, sir.
Okay. Did you ask the family history in this patient?
Yes, sir. His mother had a similar history of multiple swellings all over the body, sir, neurofibromatosis. But she had no any history of any malignancy, sir.
Okay. So what is the chance of having the neurofibromatosis in the siblings?
50%, sir.
50% of that. Good. Okay. Now, can you tell any criteria which are there, which has been laid down for diagnosis of the neurofibromatosis?
Sir, I don't remember. Two of the any cafe spots, freckling of the skin, leash nodules, family history of neurofibroma, first degree relative. Sir, I don't remember the names. Sorry, sir.
You know what are cafe spots?
Cafe spots are pale brown pigmented lesions over the skin, sir.
So what is the cafe? What is cafe?
I'm not sure.
It's a coffee
Okay, sir.
with added hot milk in that. If
Yes,
you
sir.
add the cold milk, it is not the Café. But if you add the hot milk in that, that gives an appearance of the Café spots. You know?
Okay, sir.
Right. So Café spots which are there, or the freckling which is there, or neurofibromatous nodules which are there, or there is nodules in the iris is there. Okay. Or the patient is having some type of the malignancies. So what are the various malignancies which can be associated with the neurofibromatosis? One itself, it can convert into the malignant sheath tumor. What are the
Yes.
other malignancies which can be associated with that?
In neurofibromatosis type 2, there is a risk of schwannomas and acoustic neuromas. Schwannomas.
Yes. And type 1?
No.
Okay, they are more prone for the breast cancer,
Okay, sir.
the colorectal cancers,
Yes, sir. Colorectal cancers.
leukemias. So
Yes,
they
sir.
can be all associated with that.
Yes, sir.
Did you ask the history of the patient is having the hypertension or not? Any history of that?
No history of hypertension, sir.
Achha, why did you ask that?
The history of risk of pheochromocytoma is there, sir.
Yes. PO may be there along with the neurofibromatosis. Right. Okay. And did you ask all other, like the patient is not having any hearing problem, the patient does not have any headaches, seizures, and did you ask about?
Yes, sir. There is no history of any headache or seizure, sir. No.
Okay. Okay. No headache, no vomiting, no seizures. Good. Okay.
So George, this neurofibromatosis is a part of MEN1 or MEN2 or 2A, 2B? Can you please?
2, sir.
2. Neurofibromatosis is associated with the MEN2B or 2A.
I'm not sure, sir. 2B.
And what are the constituents or other components of 2B? If you could please enlighten us.
Parathyroid, sir. Parathyroid neurosis. You
have already spoken blood pressure. Blood pressure is because of
pheochromocytoma.
this is one of the. What are the other components? Do you have any idea?
Pituitary.
Because you have to take history related to all those components also in your history portion.
Yes, sir.
Dr. George?
Sir.
George?
Sir. Yes, sir.
Can you hear me? Yeah.
Yes, sir, I can hear.
I just want to ask you, since the same syndrome has been discussed now, what are the lesions you can encounter in the oral cavity in a patient who has got this problem? Number one, general examination you may get, but at least patient may tell you. Second is, what else you will get in the neck? And what is this? Okay, quickly to tell, what else? Oral cavity. Mucocutaneous neuromas. Okay?
Yes,
And
okay, sir.
in the neck, medullary carcinoma thyroid. Okay?
Oh, yes, yes, sir.
What is this called as? Sickle syndrome. Okay? Since we are discussing neurofibroma, I just thought I will bring that attention. This you have written there, discoloration and redness and something. No. When do you get all these things? Previous slide, you have written some no issues.
Yes, sir.
Discharge. When do you get all these things?
Sir, if it is a hematoma or a chronic abscess, there can be change in color of the swelling or discharge from this.
You should know patient does not have any fever, no trauma, nothing. No. So in the order of that,
yes, sir.
Is okay, fine. You should have mentioned the size. What is important is the immediately whenever the skeletal system does it restrict its movements of the leg, that has to come first. You understand? No.
Yes, yes, sir.
That may be the reason why patients will often come to the hospital. Does he have any radiating in the leg? Like radiating pain.
No, sir. No, sir.
Did you mention? I suppose I might have missed, but I just want to ask you. These are important things. Tingling, numbness, radiating pain, paresthesia.
Any compression of the new.
That is correct. What I written, sorry, written here, no restriction, weakness, etc. These are the few, and the last ones, all this cough, hemoptysis, all that things, abdominal distension, jaundice, really not required. Okay.
Yes, sir.
What do they complain if there is a cerebropontine angle tumor, CP angle tumor?
There will be hearing difficulty, sir. Tinnitus.
That has to come first. You understand, no? So you are talking
Yes,
about
sir.
so they can also have acoustic neuron. Okay. So this is how that is a
Okay, sir.
relevant thing for patients. Okay. Right. So these are the few questions from my side.
So George, on the
Sir.
basis of history, what are you thinking of what it could be actually? Patient is a known case of neurofibromatosis, and total duration of illness is just 3 months. And patient has developed small to big size 10 to 12 centimeter of swelling in the middle part of the outer aspect of the thigh. So, given the scenario, what do you think it could be? I'm not talking about the examination as of now. On the basis of history,
Yes, sir.
what are you suspecting? What it could be?
Sir, based on a age, history of neurofibromas and a rapid onset of growth, it can be a malignant tumor, sir, most probably soft tissue, sir. And he has no other symptoms, any pain or anything else.
Any precipitating factor as far as soft tissue sarcoma is concerned, apart from neurofibromatosis?
No, sir.
Okay. Sir, can we switch to local examination or examination part, sir?
Yes, sir. Yes, sir. George, go for examination. Further slides.
Okay, sir. So the patient was examined in a well-read room after obtaining consent and adequate exposure. He was conscious, oriented, and cooperative. He was moderately built and nourished. He had multiple neurofibromas of varying sizes present all over the body. He was afebrile, hydration was fair, and ECOG score was 1. There was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Its vitals was pulse rate was 84 per minute in the right radial artery. It was regular rhythm, normal in character. Blood pressure was 110 over 70 millimeters mercury in the right arm sitting position. The respiratory rate was 16 cycles per minute. Saturation was 97% in the room air and temperature was 98.2 degrees Celsius. On inspection, the gait was normal. The attitude of the limb was hip and knee was extended. A swelling of approximately size 12 cross 10 centimeter was seen over the anterolateral aspect of the left thigh. It was ovoid in shape. The margins were not very well defined on inspection. Surface appears smooth. There were no scars, sinuses, or dilated veins over the swelling. There was no ulceration or any discoloration. There are no visible pulsations. The swelling does not become prominent on extending the knee. The range of the movements at the hip and the knee joints were normal. There was no pedal edema or no wasting of distal muscles of the limb. On palpation, there was no local rise of temperature, no tenderness. A swelling of size 12 cross 10 centimeter was palpated over the anterolateral aspect of the left thigh, which was extending from 20 centimeter below the anterior superior iliac spine superiorly and 26 centimeter above the tibial tuberosity. It was firm in consistency. The margins were well defined and the surface was smooth. The plane of the swelling was deep to deep fascia. The swelling had limited mobility in both directions in relaxed position, and the vertical mobility was restricted on extending the knee. The swelling was not pulsatile, and the left thigh circumference was higher than the right thigh circumference. Left thigh measured 58 centimeters, and the right thigh measured 49 centimeters. All peripheral pulses distal to the swelling were palpable. Touch pain and temperature sensations were normal and equal in both the lower limbs. The power was 5/5 at hip, knee, and ankle joints. There were no palpable inguinal lymph nodes. Systemic examinations was normal. Cardiovascular system and S1 and S2 was present, no murmurs. Respiratory system, bilateral air entry was present, no air sounds. Per abdomen tension, no mass palpable, no focal neurological deficits, and the spine, cranium, and log bones were also normal. To summarize, a 55-year-old gentleman who is a known case of neurofibromatosis type 1 presented with a painless progressive swelling over the left thigh for the past 3 months. On examination, a well-defined, smooth, firm swelling of size 12 cross 10 centimeter was present over the anterolateral aspect of the left thigh, deep to deep fascia, with no distal neurovascular deficit or muscle weakness.
To George.
Sir.
Rosario.
Yes, sir.
You said the swelling is deep to deep fascia. And you said this, you did that by extending the knee. This swelling is on the lateral aspect of the left thigh.
Yes, sir.
What comes there? Lateral aspect of the left thigh.
Facial lateral, sir.
Okay. So how do you put that taut? You're extending the knee. Are you putting that taut? How do you put that taut? How do you make that taut?
Extending the hip and the knee, sir.
Pardon me?
Extending the hip and the knee, sir.
What else could you do?
To abduct the hip.
Abduct against resistance. You never mentioned that. You just said extension of the knee. That is not putting the tensor fascia into I wouldn't say contraction. Wouldn't be tensing the tensor fascia later.
Okay, sir.
So
yes,
obviously
sir.
From your picture,
Yes,
this swelling is not in line with the other swellings that he has in the body.
Yes, sir, it is.
It is different.
Yes, sir.
Any of the other examiners would not take on from now?
George, did you mention any Kefle's spots in the body? I'm not sure.
No, sir, no such spots were visible, sir.
No. I think I can see some coffee colored spots. See, I can see on the chest, the trunk, lots of.
Yes.
Okay,
Sir, if we zoom it, they are nodules, sir. They are not spots. I just zoomed it and see.
No, sir. I think it is there, sir. Those nodules are there on the trunk. See, especially on the right side below the nipple. I see. Just I probably see. We can't see, but obviously these patients, sir. I can. Yeah, that's
on zooming, it looks like nodules only. We can just zoom it on our screen.
Okay, I think probably you will definitely find something. Without that, probably we can't give a diagnosis.
Yes.
One of the important criteria is the Kefle's spot. There is one thing I wanted you to carefully watch. Okay, and same as I mentioned, instead of telling routine pallor, icterus, cyanosis, clubbing, pedal edema, as I mentioned, in your case, you give more attention to, as I mentioned, mucocutaneous neuromas elsewhere. Okay.
Yes, sir.
And just examination slide. Inspection. That one slide is there. This, if you can mention horizontally, vertically.
Sir.
Horizontally, I think it is 10 centimeter. Vertically, it means lengthwise. Correct?
Okay, sir.
Lengthwise is more or 12 is what? 12 is.
Sir, I cannot hear.
It's 12 by 10 you have written. Is the longitudinal length more than horizontal?
Longitudinal 12, sir. Horizontal 10, sir.
Why I'm asking this question? That's a typical neural, whatever you can call it as. So That's how you get that, some kind of oval shape. And,
Okay, sir.
surface, of course, you are written smooth. Borders, I'm not sure really. See, yeah, margins you are written. Okay, skin over any dilated veins were there?
No, sir. No dilated veins were there, sir.
No local rise of temperature and all we are written there. So,
The swelling was firm in consistency, George?
Sir,
Swelling is firm in consistency?
yes, sir. Firm in consistencies.
Okay.
George, is the
Just wanted to
consistency?
know that, how do you know it is deep to the deep fascia? How do you
Sir,
know that?
on making it taut by extending the knee, it is swelling. If it is superficial, it becomes more prominent, sir.
So by extending and all those things, you are making the deep fascia taut?
No, sir. Muscles.
You are making the muscles taut.
Yes, sir.
So I think it will be very difficult to say that
Okay,
whether
sir.
it is superficial or deep to the deep fascia, na? Because you cannot separately taut the deep fascia as such. Na?
Yes, sir.
Whatever action you are doing, it is to the muscles.
Yes, I agree with you, sir. It is there is no test which can really tell you that it is deep to the deep fascia. Either you can test the fixity to the muscle or you can test the fixity to the tendon.
Yes,
But
sir.
it is very difficult to say that because there is no definitive test.
Yes, sir. Okay, sir.
So then how do you find the anterior sphenic spine? Where it is?
Sir, by or tracing the inguinal ligament, sir, the lateral aspect of the right foot.
There are different ways to find out the anterior sphenic spine. You can come from the
Okay, sir.
medial to the lateral side along the inguinal ligament. The first bony point which you hit is the anterior sphenic spine. Second
Yes,
is
sir.
that you can come from the thigh from below up. And again, the first bony point which you hit is the anterior sphenic spine. Or you can come along the iliac tuberosity.
Yes, sir.
And go anteriorly and where it dips down. Okay, this is a spine. Spine means it is just a very small point.
Okay, sir.
So it is not the end of the iliac tuberosity, but where it is dipping down there, that is the anterior sphenic spine. You know? So
Yes,
there are
sir.
three ways to find out the anterior sphenic spine there.
You project the slide of diagnosis.
George, did you
provisional-
look at the back of the patient in this patient? Have you
No.
examined the back of the patient?
Yes, sir. It also back also had a similar multiple neurofibroma, sir, but no other
Because
swelling.
that is the place where you will get a lot of the capillary spots.
Okay, sir.
That is the place where you will get a lot of. So you have to show again the back of the patient. You know? That is the site where you will find a lot of the capillary spots.
Okay, sir.
Okay.
Sir, provisional diagnosis of tissue sarcoma of left thigh arising from the anterior compartment with no distal neurovascular deficit, sir.
You have said that this is smooth surface, well-defined margins. And then why do you feel that this is sarcoma?
Sir, patient is because it is a rapidly growing tumor, sir, within 3 months.
Yes.
In the extremities in the thigh, it's a common site of sarcoma, sir. The thigh, it is present in the thigh, sir.
Yes. Then one more thing is there in it, which points that it could be a sarcoma. What about the size of the tumor?
Yes, sir. Large tumor, sir.
Yes, it is large tumor. Where do the sarcomas metastasize? How is the metastasis that occur from the sarcoma?
Sir, sarcomas commonly metastasis through the bloodstream, sir, hematogenous blood, Most commonly to the lungs, sir.
Yes, but what is the route of metastasis? Is it lymphatic spread? Is it hematogenous
Hematogenous, sir.
spread?
Hematogenous spread, sir.
Yes. So that is why you may not get regional lymph nodes. So you will not get inguinal lymph nodes.
Yes, sir.
Lymph node may be absent, but still you will see metastasis in the lung, because generally the metastases are by the hematogenous route.
Yes,
So
sir.
what was the situation in this patient? There were any metastasis in the lung?
There was no, sir.
Yes. If one more quality was present in this particular swelling, then you could have said that this is a
There was no
macular
metastasis.
swelling. Pardon?
Sir.
If the swelling was bosselated, then that would perhaps give you a clue that perhaps this swelling is sarcoma, you know.
Okay, sir. Yes, sir.
Because you need to differentiate, because this could be very well be a large lipoma. You know, you cannot, you have to say that something is sarcoma because it has got certain characteristics of sarcoma. So
Yes,
based
sir.
on that, you have to make these comments. So one is your size here, and second one is rapid growth. And third thing, if it was a bosselated, then
It could be,
you could
sir.
have gone more closer to sarcoma. But yes, two things, rapid growth and large size is also good enough to, you know, put it as sarcoma. How will you confirm your diagnosis?
To confirm the diagnosis, we need a tissue biopsy, sir. So
Yeah.
before that, I will have to go with imaging, sir. First, do an imaging with a MRI, sir, followed by a core needle biopsy, sir.
Yes. So you said that this is soft tissue sarcoma. Do you know any other sarcoma that is seen in the thigh region or lower thigh region?
It can be osteosarcoma, sir, from the
Yes.
bone. Also, sir.
It's not osteo, it's osteogenic sarcoma.
Yes, sir.
Okay. George, what are the common sites of soft tissue sarcoma in the body?
Sir, most commonly it is seen in extremities, sir, in the upper limb and lower limb, sir. Followed by the trunk, sir.
Followed by?
Trunk, sir, trunk.
Okay. Trunk.
Yes, sir.
Trunk. Okay. And which
Then,
is most common?
Most common is extremities, sir. About 50 to 60% are seen in extremities.
Okay. And do you get lymph node involvement in soft tissue sarcoma?
Usually not,
If
sir.
yes, then how many percentage? What percentage of the patient have soft lymph node involvement?
5%, sir.
Less than 5%.
Can you tell which sarcomas can metastasize the lymphatic route?
Sir, usually rhabdomyosarcoma, sir.
Yes.
Rhabdomyosarcoma, angiosarcoma,
Mhm.
clear cell sarcoma,
Mhm.
synovial sarcoma. Usually can metastasis through lymphatic route, sir.
Mhm. Yeah, you can remember by the races, you know, RACES. Rhabdomyosarcoma,
Yes.
angiosarcomas, clear cell
Epithelioid sarcoma,
sarcoma,
angiosarcoma, clear cell sarcoma,
epithelioid sarcoma,
epithelioid sarcoma, and synovial sarcoma.
synovial sarcoma. You know? By that, you can remember that which are the sarcomas which can metastasize with the lymphatic route.
Yes, sir.
Okay. So, can you stage your patient?
Sir, to stage the patient, we also need the grade of the tumor, sir.
Okay. So, before the grading, what is the stage here?
T3, sir, based on size, sir.
What is the size?
T3, 10 to 12, 10, 12 cross 10 centimeters, sir.
Okay.
T3 N0 M0, sir.
And how does the grade matters there?
So depending on the grade, the grading is also included in the staging of soft tissue sarcomas.
Yes. So how does that make the difference in the stage, the grading?
If it is grade 3, it will be stage 3, sir.
Yes, even if it is a small tumor is there and the grade is high, it will increase the stage of the disease, isn't it?
Yes, sir.
Yes. Okay. So you want to keep any differential diagnosis apart from the sarcoma here?
It can be a large lipoma, sir. Maybe. It has no other associated symptoms, painless swellings, but the duration is contradictory.
Can it be chronic inflammatory swelling?
It can be, sir, but he has no associated systemic symptoms of any. So
So if
less
the
like.
chronic inflammation is there, what are you going to get?
Yes, sir.
I say it is tubercular. Can it be tubercular? Oh, it is just for, for
Yes, sir.
discussion purpose. Can it be tubercular?
It may be, sir.
Are you sure it may be? Because for that to be a tuberculosis, you need to have some basic tissue over there, where the tuberculosis should affect that particular tissue. Say, for example, there are lymph nodes there which are affected by tuberculosis, or some tissue that can affect the tuberculous bacillus can affect that particular tissue. So do you have any such tissue on the lateral side of the thigh where the tuberculosis is seen? Have you seen any tuberculosis on the lateral side of the thigh?
No,
Anytime?
sir.
Then
No, sir.
how will you?
Tuberculosis can affect any tissue in the body.
Yes.
Okay, it can affect any tissue in the body. It may be from the skin tuberculosis, it may be there. It may be from the muscle, it may be there. It may be from the bone, it may be there. So any tissue which is there, you can have the tuberculosis. It's not necessary that you require the lymph nodes and the Peyer's patches and the intestine and all those for that, or the lung tissue. It can occur in any place, right? So that should be kept as a possibility, though it's a remote possibility. But just for the discussion's sake, you can keep it.
Yes, sir.
Yeah. Okay, so how will you proceed with your in this patient?
Sir, first I would like to do imaging, sir. Since it is an extremity, MRI is the investigation of choice, sir.
Have you done the MRI in this patient?
Yes, sir. MRI.
Can you show the picture?
Yes, sir. One minute, sir.
You're not able to show it?
Yes, sir.
No. Okay.
Sir, MRI showed a growth in the vastus lateralis muscle, sir.
What did it show?
It has a growth in the vastus lateralis muscle, sir.
What is
With
growth?
John,
This is
you
the growth?
should know. Yes, sir. John,
Sir?
People should know. Don't read the diagnosis of MRI and speak. Just say what type of a lesion is that, then come to the diagnosis. Like we say in ultrasound, we say hypoechoic, hyperechoic, isoechoic.
Yes.
So that is how you should try to see what is it, extent, vascular, then only you give a final diagnosis.
Yes, sir.
Never see the growth on MRI, isn't? There's nothing like a growth on MRI, you know?
Okay, sir.
There is to a mass or space occupying
sir.
lesion
Sorry,
is
sir.
there. All those terms are used, never the growth, you know?
Yes, sir. Sorry.
Yeah, so tell about that now, that there is a mass which is involving the
Vastus.
Describe the mass that you are seeing in the MRI.
What is it? Yeah, tense. We relate in terms of tense. Like what?
Sir. Hello, sir.
Somebody is speaking. I don't know.
Sir, I will mute
Sir.
everyone, sir. Please unmute yourself, sir.
George, will you explain now? There is a lesion. What is that lesion? Just explain.
Sir. Hello, sir. Sir, am I audible,
John,
sir?
you've been asked
Yes,
to
you are
explain about the read the film.
Okay, sir. Sir, the MRI of the left thigh, sir. It shows a T.
you know, in MRI, you have to always tell whether it is a T1 weighted image or T2 weighted image, you know? You have to always tell that.
Yes, sir. T1 weighted image. It's sir T. Hello, sir.
Yeah, please.
Sir.
George, please go
Yes, sir.
ahead. See, we want, as
Sir.
Dr. Khanna said, say growth. You understand? No, I have already given you a clue. In ultrasound, we use echogenicity.
Yes, sir.
In CT scan, you use the density. So in that order, what do you use it? Please go ahead.
Whether it is hypointence or hyperintence, sir. When in T2 and T1, sir. Lesion in soft tissue sarcomas, usually T1 hypointense lesions.
What is here? What is here in this plate? If you can read the report also, that's fine. If you don't know, doesn't matter.
So, okay, sir.
Yes, that will be better.
Do you have MRI report with you, George? By any chance? If you are having report, then please read it.
Yes, sir, I have, sir.
Yes, so read it and then
okay, sir. Ill-defined T2 hyperintence and T1 hypointence mass lesion of size 10.3 cross 7.6 cross 5.2 centimeter is noted within the vastus lateralis muscle in the left proximal thigh, about 13 centimeter inferior to the greater tuberosity of humerus. The lesion shows necrosis with a few areas of T1 hyperintensities within, suggestive of acute hemorrhage, sir. The solid areas show a diffusion restriction within, sir, with minimal perilesional fluid is noted. There is no subcutaneous plain or adjacent muscle invasion is seen. The rest of the surrounding muscles and tendons and neurovascular structures are normal.
So this tumor is localized to the vastus lateralis only, isn't it? Hello. Hello.
George, sir is asking, can you hear us, George?
Hello.
Yes, sir.
So this
Yes,
is
sir.
only localized to the vastus lateralis only, isn't it?
Yes, sir.
Okay. No other muscle involvement is there?
No, sir.
Okay. Neurovascular bundle is okay?
Yes, sir. No, not infiltrated, sir.
Okay. All right. Okay. So after this MRI, what did you do?
I did a tissue biopsy, sir, core needle biopsy, sir.
Okay. How did you do a core needle biopsy? From which place you have done the core needle biopsy?
Under the most superficial part of the lesion, sir. Under
Was it guided biopsy or unguided?
You use a lot of hemorrhage.
sir, we did an unguided biopsy, sir. Yes, sir.
So if you do unguided biopsy, you will be in only the blood clot may be there.
Yes, sir. It's better to do a guided biopsy.
Now, when you're doing a biopsy in a case of soft tissue sarcomas, what are the various precautions you have to take? Like if you're doing an open biopsy, okay, not the core needle biopsy, but if you're doing an open biopsy, what are the various special precautions you have to take?
Sir, the incision should be made in such a way that it should be possible to resect it completely in the future excision of the tumor, sir.
Right.
Ideally, this biopsy should be done by the surgeon who is going to operate, sir.
Okay.
There should be the flap should not be elevated, sir.
Yes.
Complete hemostasis should be achieved.
Right. And are you going to put the drains after that or not? When you're doing a incision biopsy, will you put a drain or not?
It's better to avoid. It's better to achieve complete hemostasis and avoid placement of drains, sir.
It should not be put, no?
Yes, sir. It should not be put.
Right. Okay.
In fact,
why wouldn't you want to use a drain, Dr. George?
Sir?
Why would you not want to use a drain?
If we place a drain, it should that area will also have to be included in the future resection of the tumor, sir.
Question is, why do you don't want to use a drain? Why should you not use a drain?
It can distort the anatomy, sir.
No. Tumor seedings along the drain tract.
Okay, sir.
That is the reason you should not use a drain when you do an open biopsy for a soft tissue tumor. I'm not saying sarcoma, soft tissue tumor. You don't know whether it's what the pathology comes till you've got a histopathology report. So it's a soft tissue tumor. Do not use a drain.
Yes, sir.
Why are you really worried about the tumor seeding or involvement of the skin? Does it make the difference to the stage of the tumor?
No, sir. But
yes. Skin involvement, will it make a track involvement? Track seeding?
No, sir.
If that is not an issue, then you should have put the drain in.
Yes, sir.
But drain should not be used. Sir is asking.
That is done, sir. That is done. That is the point.
It should not be used. That
It
is
should not be
very
used.
well acceptable.
Yes,
It should not be used.
Yes.
But if we are using the drain, the seedling is the property. Now, sir is asking, does involvement of skin is going to change the pathology or stage and your management plan? What you have decided before doing the biopsy?
No, sir. But increased risk of metastasis, sir, due to handling. It won't change the stage, sir.
Now the question is, your tumor was localized in the vastus vestalis only.
Yes,
there
sir.
was no involvement of the surrounding tissue.
Yes,
now
sir.
skin is involved because of your biopsy, and you have put in a drain, and now the skin is also involved because of the tumor seedling.
Yes,
so
sir.
don't you think there is change in the staging of the disease?
I'm not sure, sir.
Have you done the biopsy in this patient or not?
Yes, sir.
Okay, so what is the report of that?
Sir, a biopsy showed high-grade round cell sarcoma, sir. A core needle biopsy, sir.
And what is the grade?
Sir, grade 3, sir.
Grade 3. Okay. So you want to do any other investigation for this patient?
Metastatic workup, sir.
You have to do the metastatic workup. No?
I would like to do a CT chest, sir. Yes, sir.
Right. Has it been done?
Yes, sir. CT chest was normal, sir.
Okay. Anything in the abdomen?
Abdomen was also normal, sir. There was no metastasis, any metastatic deposits, sir.
Okay. So what is your plan now?
Sir, I would like to proceed with the wide local excision of the tumor, followed by post-operative radiotherapy.
Do you think it's a resectable tumor?
Yes, sir.
Okay. What are the various types of surgery which are done for the soft tissue sarcoma of the limbs?
Most commonly, wide local excision, sir. Wide local excision of the tumor with about 1 centimeter margin, sir. If the tumor is very large or multifocal, we have to do a compartment excision, sir. In rare cases, we will have to go for amputation, sir.
So what are the indications of amputation in the soft tissue sarcoma?
Sir, if the tumor is very large or involving more than one compartment, then any involvement of bones or joints, or any severe major neurovascular invasion which cannot be reconstructed, sir.
And the fungating sarcomas, what everyone is asking you, that putting the drain there, you said this, it will not change. Okay, so it can fungate from there. And fungating sarcoma is itself is a bad thing. So you have to land up sometime in the amputation because of that. Okay. So has this patient been operated? George, has this patient been operated?
Yes.
George, are you there?
I think he's lost connectivity.
Okay, sir. Yes.
He has
Hello.
some
Can
issue
you
with his connectivity.
hear us?
Yes, sir.
George, are you with us?
That I think since till he comes that American orthopedic surgeon, Emmy King, I think he is the one who proposed some of the nomenclatures like marginal excision, then intralesional, especially what happens in retroperitoneal sarcoma, that you will not be able to sometimes get even the full wide margin sometimes. So that's marginal excision, intralesional, going wide and all that. Is orthopedic.
Sir.
George is back, sir.
Sir,
George, your
you hear me,
pathologist has
sir?
advised some immunohistochemistry.
Yes, sir.
That is
So-
pending. Yeah, what is that
So,
immunohistochemistry?
What
Is pending.
immunohistochemistry you are going to do?
Sir, it can give an idea about the possible cell of origin, sir.
So which one you are going to do?
CD 3134, sir, for Leo, sir. From it is since it is from muscle, sir.
So do you think the leiomyosarcoma is there in the thigh?
No, sir.
Hmm.
Sir.
In the thigh muscles, vastus lateralis, which sarcoma you mean?
Leiomyosarcoma is also smooth.
Hello?
Rhabdomyosarcoma, sir.
Rhabdomyosarcoma. What are the various types of rhabdomyosarcomas?
Rhabdomyosarcoma, sir. Sir,
What are the various
in
types of
pediatrics,
rhabdomyosarcomas?
in pediatrics, embryonal rhabdomyosarcoma, sir.
Yes. Any other?
Not sure, sir.
Botroidus? Botroidus variety? Pleomorphic variety? Embryonal variety? No, they are the various types of rhabdomyosarcomas here.
Okay, sir.
George, is this patient
Yes.
operated?
Yes, sir. Operated, sir.
What operation you have done?
Wide local excision, sir.
Wide excision.
Yes, sir.
How much wide?
Sir, with a gross margin about 2 centimeter margin, sir. We excise the vastus lateralis muscle including the growth, sir.
Okay. So biopsy report has come post-operative.
Yes, sir. Biopsy report has come, sir.
Resection margins negative.
Sir, yes, sir.
What is the status of? What is the margin status?
Sir, margin were more than 1 centimeter margin was present all around, sir.
No. Margin status or tumor free or is
Free,
there
free,
any?
sir. Tumor free, sir.
Free.
All margins were
So,
tumor free, sir.
are you planning to do any radiotherapy or chemotherapy in this patient? You are going to offer this patient?
I would like to do a radiotherapy, sir, since it is a high grade tumor, sir, and large tumor.
You do not want to offer the adjuvant chemotherapy here? Okay, it is a synovial sarcoma, that is a bad sarcoma. It is
Yes,
a
sir.
high-grade tumor.
Yeah.
No.
Chemotherapy can also be given, sir.
I think it should be given, no?
Synovial sarcoma.
So in this way, yeah. So it's a bad tumor, no? Synovial sarcoma, a
Yes, sir,
large
yes.
tumor which is there, no? With a poorly differentiated type. Okay, so this probably will need both the radiotherapy and the chemotherapy.
Chemotherapy.
Yeah.
George, what is the effect of chemotherapy and the radiotherapy on the overall patient survival?
Sir, it helps. It can prolong the. It can reduce the chance of recurrence, sir. Recurrence and metastasis, sir.
What is the the longevity of the patient as far as concerned? Is there any survival advantage with the chemotherapy or radiotherapy? Disease specific.
Local
difference. It has no impact on the overall survival.
Overall survival.
I know.
Yes.
Khanna sir, do you agree with
George,
me?
what is the pathological staging here? Can just we are not able to read it. PT.
Sir, T2, NXMX. NXMX. Sir. Sir, in the here the specimen size was given as 9 centimeters, sir. 9.5 cross 9 cross 7.2, sir.
But the grade of the tumor is it's a poorly differentiated, isn't it?
Yes, sir.
So how it can be
stage
What is the stage here?
Stage will be stage 3, sir.
Yeah, it will be stage 3.
Yes, sir.
So one or two things, sir, I would like to add, that is, when you have got, if you have got a high grade, means it is a candidate actually is for PET scan here. If he is a, since he has mentioned high grade, correct? George,
Sir.
can you hear me, George?
Yes, sir.
Initially,
I can hear you, sir.
Initially, you told round cell, correct?
Yes, sir.
And now you finally spindle cell, correct?
Yes, sir.
What is the difference as far as the chemotherapy is concerned? Any specific thing you'd like to? Which is more sensitive for chemotherapy?
Synovial sarcoma is sensitive to ifosfamate, sir. So we can give.
What I'm trying to indirectly tell is round cells are more chemosensitive. Round. Okay.
Okay,
Anyway,
sir.
they very high. So he differentiated tumors and all, like poorly different written there. The response is not good. So, this patient to be evaluated now further by actually PET scan. This one, and local,
Okay,
they have
sir.
written some. If I'm not wrong, because the report is quite big, local fat is also infiltrated, correct?
Yes, sir.
Subcutaneous fat. That means it has breathed through the facial lata.
No.
The tumor.
No, sir. Sir.
Then you have written your tumor invades the subcutaneous fat. You have written there, something like that.
Yes, sir.
Local recurrence. That is another thing you would like to keep it in mind to prevent that RT. Local RT, I think, is required. So these are the few observations. So these
Okay,
are
sir.
from my.
George,
Sir.
can I ask one or two questions?
Yes, sir.
See, if you suspect synovial sarcoma before the biopsy report, I mean before surgery, you have to concentrate on one examination. What is
Sir.
that exam?
Up.
Am I audible?
Spine, sir.
Am I
Hello.
audible?
Perfectly audible, sir.
George,
Sir, you are audible, sir.
George, just now
Yes,
we
sir.
discussed about that,
Yes,
Just now we
sir.
have discussed about that. I gave you formula of races,
See, if you
I-
suspect synovial sarcoma before surgery, you are supposed to do one examination. What is that?
Abdominal examination, sir. Abdominal examination.
You are supposed to examine the regional lymph nodes. So there are
Yes.
certain sarcomas that may spread to lymph nodes. One among that is synovial sarcoma. What are the other sarcomas that may spread to lymph nodes?
Sir,
Sir, we have
abdominal sarcoma, sir. Angiosarcoma. Clear cell sarcoma, sir.
sir, he has this question. He has answered, sir, that question.
Okay, sir. Sorry, sir.
So, because no, not yet. I just that we have asked that lymph nodal spread, sir. Dr. Khanna sir has asked, sir, and he has answered that. Just
Okay,
I
sir.
thought
Sorry,
I
sir.
said.
In this patient, I am not sure, does the neurofibromas, they pick the PET scan or not? If you do the FDG scan for these, because if you do a PET scan in this patient, and if the neurofibromas will take, then you will think it is all over metastatic is there. It is just my query, to everyone.
Sir, generally, nobody is required to do PET scan for neurofibromatosis because the diagnosis
No,
is evident.
in this patient, if we do the PET scan,
Uh-huh.
and I'm not sure whether the neurofibromas, they pick up the FDG or not. If they pick up the FDG, then it means it will be all over metastatic disease. by the PET scan. So PET scans probably should not be done if that is a doubt.
Okay, the point is well taken, sir.
Mhm.
Khanna sir, are you sure, or you have some doubt about
No,
that?
I have a doubt. I have a doubt.
So
Yeah.
I think by next Friday, one of us should clarify it with the
Right.
department. Yes.
Yeah. I have doubt. Yeah. I have doubt.
Yes, I got your point. It's
Yeah.
nice to be learning. Yes, sir.
Mhm. Okay. Can we move to the next patient now? Next case?
Yes, sir. Should we allow the candidate to ask any doubts if he has, sir? George?
Sir, no, sir. I will.
Do you have any questions, Dr. George?
No, sir.
Okay. Good luck to you and thank you for joining this evening. Please
Thank you, sir.
unshare your screen. Dr.
Yes, sir.
Pooja, please introduce yourself and start your presentation. Good luck to you.
Yes, sir. Thank you, sir.
Can I go to the first slide? Yes. Good luck to you. Make it full screen.
Yes, sir. Yes.
Please introduce yourself, your unit chief, head of the department, and start your presentation.
Good evening, faculties. Myself, Dr. Pooja Jain, second year general surgery resident. My PG teacher is Dr. Hitesh Andaria, sir, and my head of the department is Dr. Asit Patel, sir. My case presentation is regarding varicose veins. 48-year-old male patient, a resident of Ahmedabad, who is a laborer in pharmaceutical company, has to stand for long period for packaging drugs, presented with chief complaints of swelling of veins over left lower limb inner aspect for past 7 months and pain in left lower limb since past 4 months. Patient was apparently asymptomatic 7 months back, after which he noticed dilated tortuous veins on inner aspect of left lower limb from groin to ankle. This swelling was insidious in onset, has not significantly increased after his first notice. Swelling of veins becomes more prominent on prolonged standing, decreases on lying down. It was associated with pain in left leg since 4 months, which was dull aching in nature, occurs more towards the end of the day and is relieved by resting. No similar swelling on right lower limb, and there is no history of any abdominal symptoms like lump or distension. No any history of comorbidities like diabetes mellitus, hypertension, or any lymphedema. No past history or features of suggestive of superficial thrombophlebitis or any surgical procedures or tuberculosis. Personal history: patient works in packaging and dispatch, has long-standing hours. No history of any addiction. Bladder and bowel habits normal. Family history: no significant family history or similar illness in family members present. Sir, in summary, after history, a 42-year-old male patient presented with the complaint of dilated tortuous veins on medial aspect of left lower limb from groin to ankle for 7 months, which increases on prolonged standing and associated with dull aching pain over left lower limb for 4 months, which increases in severity on prolonged standing. In general examination, patient is examined.
Pooja, wait.
Yes,
Let us discuss the theory. Any examiners, please, sir.
yes, sir.
Faculties, any questions in history?
You said the swelling is from groin to ankle or swelling is from ankle to groin? The summary you have mentioned as the swelling is from the groin to ankle.
Sir, patient presented with this complaint. In patient's word, the complaint was swelling is from groin till ankle.
No, what do you normally expect?
Sir, from ankle to groin.
What
At
is
least in
groin?
summary.
What is groin?
Sir, crease till.
So it extends up to the crease.
Upper thigh, sir.
Groin
Upper thigh region.
Groin is a region. It is not a line.
Yes, sir.
So groin includes inguinal region. When you are juxtaposition of the limb, the area comes into contact, abdominal, inguinal region, femoral region.
Yes, sir.
So what exactly you mean by that, and where up to where you are getting a swelling? Is the patient is saying that the swelling comes in the groin to angle?
Sir, upper medial part of the thigh.
Okay. So
That
because
should be more appropriate.
when you are presenting, it is you are presenting in the way it is being acceptable. You are saying repeatedly saying that groin to angle. That means it is we are expecting the swelling. The problem is only there.
Yes, sir.
And why you say that the pain is increasing in the night and increasing and then relieved by resting? How it is happening?
Sir, over the day
Why
when
there is pain?
Sir, pain is at the region of the dilated vein, and sir, when patient gives history of when patient is working for long hours, the pain is increasing, but in the evening when he rests and when he stops walking and standing, the pain is relieved.
See, if you are talking of a pain which occurs while the patient is working and it is relieved on resting, what kind of pain that is? What kind of pain that is known as?
Claudication. So.
Then how does it differ from pain of varicose veins? There is a difference, no?
Is it on walking or doing exercise, or even at the end of the day after standing? That is what sir is asking.
Yes.
The pain is at the end of the day as well on standing.
Yes. Yes.
Yes.
Yes.
What is the criteria to say a pain is a claudication pain?
Sorry, sir.
What are the criteria to say a pain as a claudication pain?
Sir, when patient complains that it increases on any physical activity like walking and running, and it gets relieved on resting.
How do you define claudication? How do you define claudication? See, when the patient starts walking, there should be no pain. Then what happens?
Then once patient starts exercising, the pain gradually increases.
What is the type of pain there?
So throbbing or bursting kind of pain.
No, it is not throbbing, not bursting. There is a typical word.
No, that means you need to study on the pain, and you must understand why there is pain. Because varicose vein, is it supplied by the skeletal nervous system or somatic autonomic nervous system?
Autonomic.
The pain is arising from where?
Venous.
Okay, so what kind of stimuli will cause pain in an autonomic system or a vein? Only distend or collapse. So as you walk around, there is a more and more blood are staying there, vein distending, and you will get slowly getting a pain. It will not be a localizing pain. And what is night pain?
What is night pain, sir? I did not get your question.
Night pain in the night. This
sir,
is
cramping
different
kind of
from
pain.
what your patient will say.
Sir, cramping kind of pain.
The patient will have the typical history, how he relieves the pain and what type of pain he is getting. So the varicose vein and the peripheral vascular disease, and you need to concentrate more on understanding what type of pain, what exactly is happening with the pain. Don't just go away with saying he has a pain at the wrist pain. You must understand what exactly the patient is feeling. And most of the time, patient will be able to tell it in a proper way, how he is relieving that pain, putting his foot on the bed, pressing on the foot pump, you will be able to have the pain. So that you need to engage. Have you asked any question related to the complications of the varicose vein?
Yes, sir. I asked if there was any pigmentation or any discoloration of the skin that he has noticed, or if there is any itching in the
Where?
itching in the gaiters area or on the foot. And if patient has any past or previous history of venous ulcer which is healed, or any skin.
What does it indicate? The patient, you have a patient comes with a varicose vein with all the cutaneous changes, and one patient is not having any cutaneous changes. What do you understand by that? Is it a superficial varicose vein produces these changes, or anything else?
Sir, the one with the ulcer and skin changes, deep venous system is also involved, and with no skin changes.
That's good. Exactly. That is very important. When he has a cutaneous changes, it always indicates more so the patient has post-phlebitic limb or the chronic limb ischemia, where this patient has the deep pain. Also, sometimes somewhere it has been involved. It's the local changes. Any systemic changes, complication it can produce?
Sir, pulmonary embolism, if DVT is present or if there is any past history. Patient will have history.
No, how will you ask the history? You will not ask whether you have a pulmonary embolism. No, how will you ask the history of the patient?
Patient has any complaint of breathlessness.
Not only breathlessness, their breathlessness will need hospitalization in ICU.
Yes.
So only pulmonary. Okay. So when a say simple varicose vein case is there, and when you have, especially when you have a cutaneous changes are there, you must always think the possibility that embolic manifestations or whether it has gone to the any local damages which has been associated with diseases. It is a peripheral limb. Suppose patient has a peripheral neuropathy due to diabetes and varicose vein pain, how will you be able to differentiate?
So loss of sensations will be present to heat or cold in diabetic neuropathy.
To cold or what is that? Diabetic neuropathy due to cold?
No, patient will have loss of sensations on the extremities or decreased sensations.
Really? Is the patient a loss of sensation or it is a painful one? Peripheral neuropathy is a painful one or a painless one?
Painless. In diabetics, sir, it would be painless.
Then there is no problem. Nobody will complain, come to you. That is what you are seeing is under surface, the sensation. But the typical neuropathy pain is a blow and stalking pain. What you have a typical pain will be there, and that you need to differentiate that pain, the rest pain, which will have in an arterial disease.
Yes, sir.
How it will be a continuous pain. How will you differentiate from a diabetic neuropathy pain and the rest pain? Now both the nerves are damaged, they are getting the pain. And it will be a continuous pain.
Yes.
So by what relieves the pain? You have to know what relieves the pain and what is the attitude of the limb the patient is keeping. So that will be telling you whether it is an ischemic pain or whether it is a neuropathic pain which the patient is having. So normally varicose vein, when we are giving as a long case, it will be given normally as a short case. It is given as a long case. You need to go in depth, ask all the associated diseases, associated problem, what are the inducing things, everything should be asked in the history.
Yes.
Okay. You can go ahead with the clinical examination.
Sir, in general examination, patient is examined in well-lit room with proper consent. Patient is conscious, cooperative, and well-oriented to time, place, and person. Patient is moderately built. Vitals are normal, and sir, no pallor, icterus, clubbing, lymphadenopathy, or pedal edema or cyanosis present. Sir, on local examination, on inspection, dilated, sir, on left side, dilated tortuous varicose veins present over anteromedial aspect of left leg extending up to upper thigh of left lower limb, with a large bunch of multiple similar veins at the level of calf more anteriorly. No such varicosities over right lower limb present, no limb deformity, and no pigmentation, ulcer, or edema. Sir, on sir, in this picture, on resting, on normal resting position, patient has dilated tortuous vein on medial, anteromedial aspect of leg of left lower limb, and So then on palpation, on left side, no raised local temperature, tenderness or edema present. Peripheral pulses are palpable and normal. So Brody-Tenelenburg test was done. On keeping the tourniquet, filling of great saphenous vein from below was suggestive of positive test. And on removing the tourniquet, it was inconclusive as vein gets filled from below immediately on standing. So I kept 2 tourniquets at the level of SFJ, just below SFJ and above knee. On removal of the upper tourniquet, sudden filling of GSV from SFJ above downwards was present. So on multiple tourniquet tests, multiple incompetent perforators were present in lower thigh, leg and ankle. Modified Perthes test was negative and Schwartz test could not be appreciated due to tortuosity of the vein. So on right side, no raised local temperature or tenderness, no pedal edema. Peripheral pulses palpable normal and all tests were negative. So this test was done.
What is the status of the peripheral pulses in the left lower limb? Did you mention? I forgot to see.
Sorry, sir.
Dr. Pooja, did you mention about the peripheral pulses examination in the left lower limb?
Yes,
She has mentioned.
peripheral pulses were palpable and normal.
Okay.
Yes.
Okay. Sorry. Yeah.
Yes. So then I performed various tests to see the incompetence. Brody-Tenelenburg test, multiple tourniquet.
When you perform this Brody-Tenelenburg or multiple tourniquet, what type of tourniquet you are supposed to ideally use?
So pneumatic cuff.
Pneumatic?
No need to pneumatic, man. No need. Sir is asking what is the ideal characteristic of this tourniquet you are using?
Yeah, because I see in the picture that you have tied a simple bandage over there. The whole idea is the tourniquet should give adequate compression to compress certain parts of the vein. So what type of a tourniquet, what tourniquet you should ideally use?
Which compresses superficial system.
Anything else but this bandage?
You have to use latex tourniquet. Tourniquet should always be latex. If at all the bandage does not give adequate compression at any particular point, your results of the test will be erroneous.
Yes. Commonly, the students use Foley's catheter.
Yes, sir. Students are using even the bandages. In my institute also, students are using bandages because classical, that 1 meter to latex tubes are not available these days.
Yes,
so they
yes,
are using.
In thin limb, sometimes students use Foley.
That is, I asked this question just should they know that what is
Yes,
the...
yes, exactly. Exactly, sir. Yes, very good.
You can use the IV infusion set, IV infusion set, which is there, you can use. It's
Yes,
a long one and you can make 4 or 5 of that. Okay, Foley's catheter maybe because you have to require 3 or 4 or 5 of Foley's catheter. So that may be a little expensive. But if you use just one IV infusion set, that will suffice here.
Okay, sir.
Pooja, in this you are saying on keeping tourniquet, there is a filling of GSV from below, suggestive of positive test. What do you understand by that?
Sir, on keeping the tourniquet, the veins, sir, on medial side and anterior side, they became more prominent, which suggests positive, which suggests that perforators are incompetent. Incompetence of perforators, sir.
No, so you say suggestive of positive test. Positive for what? Saphenofemoral junction or for the perforators?
Sir, for perforators.
For perforators.
I think positive test should not have been used. It is mainly for SFJ. So you just say that it fills up from below. Yes, sir.
Pooja, there are various components of these varicosities. So the various components are, one is long saphenous vein, second one are the perforators, the short saphenous vein and deep veins.
Yes.
So after doing so many tests, After doing so many tests, what is your assessment? What all things are affected in this particular patient?
Sir, in this patient, superficial venous system, great saphenous vein is incompetent, SFJ is incompetent, sir, perforators are incompetent, and sir, deep venous system is normal.
One
You
more
have done
thing left, which sir asked you.
Yes.
You should have mentioned the lateral surface,
Lateral surface.
which is not, so short saphenous is not involved.
Yes, sir. Lateral surface is, sir, no dilated tortuous vein on lateral side of the left lower limb.
Where do the perforators open? Well,
Sorry.
these perforators, these correct the deep vein.
Yes,
But
sir.
where do they open up?
Sir, in the superficial vein, like cocket perforator, they open into posterior arch vein.
Yes.
Can you say that what is that superficial vein and deep vein for the angle perforators?
Sir, for ankle perforators, superficial.
So which
Yes, sir.
superficial
Cocket.
vein and which deep vein it connects?
Sir, for ankle perforators, superficial vein would be cocket perforators and posterior arch vein, and deep would be anterior tibial and posterior tibial vein.
Good. It is not the saphenous vein, it is a posterior arch vein. It is.
Posterior arch.
And in your tendon lumbar test, you said there is a two tourniquet were applied. What is that test?
Sir,
simultaneously you applied two tourniquet.
Yes, sir.
What is that test?
Sir,
Why did you apply two tourniquets, one at the SFG and one above knee, which you mentioned? Why did you require to do that?
Sir, to demonstrate SFJ incompetence. Sir, because in Brody tendon work, and as soon as patient gets up, we have to open the tourniquet to see the vein filling from above downwards to show the SFJ incompetence. But in this particular patient, the veins were filling up as soon before removing the tourniquet itself. So
yes, you are suspecting perforators incompetence, and you can do the multiple tourniquet test.
Yes, sir.
And why do you wanted to do a separate test by putting in another test? If you are doing, say that I am doing a multiple tourniquet test to assess the tourniquet, multiple perforation, that is accepted.
Okay, sir.
If you think that you are is an accepted one. Second, you have said you have done a modified Perthes test here, and the patient is already having all the veins are dilated. You say even if after this ephemeral junction is ligated, the veins are filled up. And what is the purpose of doing a modified Perthes test?
Sir, to test for DVT, to rule out DVT in the patient.
What you are in the DVT? What you are going to look for?
Sir, if patient, sir, in performing modified Perthes test, we will we will put a tourniquet just below saphenofemoral junction of the affected leg, and we'll ask the patient to walk fast for 5 minutes. Okay. If the patient has crampy or bursting pain, it is suggestive of involvement of deep venous system.
No, that is a subjective. The pain is a subjective. What is important in the modified Perthes? An objective. You are going to see the dilatation of the vein. The perforators dilatation of the veins you are going to see.
Yes, sir.
In a case already when the perforators are incompetent, the modified Perthes test is not going to give you any objective evidence. Yes. It is only a subjective evidence patient will have the pain or not. That is why from Perthes test it is changed to modified Perthes test, that we should include the objective element also.
Okay.
So there is a difference of the school of thought is different for people. Some of the examiners do not. Perforators, when there is perforators incompetent, to do the modified Perthes test.
In modified Perthes test, what is done is you don't wait for pain, because for pain, you might have to make the patient walk for a long time, and it may take certain time. But in modified Perthes test, you fix up certain distance and then see whether there is a dilatation of the veins.
So in this patient, without walking itself, there is dilatation.
Yes, sir. Yes, sir.
And Swartz test, because that the tortuosity, you are not able to get the Swartz test. Why?
Sir, on tapping with the right middle finger on the lower end of the dilated vein around mid calf, sir, thrill, I could not appreciate the thrill over SFJ.
So, is there a tortuosity is the reason for that? The varicose vein itself has to be tortuous. Only then it is a varicose vein.
Yes, sir.
So you said Swartz test is could not be done because that is tortuosity. When you are presenting, you said that. What does it indicate? Swartz test positive means what does it indicate?
Sir, SFJ incompetence, if
SFJ incompetence you are doing by Trendelenburg vectors.
yes, sir.
And here what you are doing is a single column of blood. All the blood, the walls in between all lost. So there is a single column. And the patient like this who's having a multiple perforators incompetence, and if you are not able to get Swartz sign properly, you are not eliciting it properly. And the patient is erect, standing. If you try, you would have appreciated that.
Okay, sir.
Okay.
Yes.
Pooja, when you are doing the multiple tourniquet test, which tourniquet you open first?
Sir, from above downwards.
Hmm?
Sir, from above downwards. Keeping
How do you ligate it?
sir, first we empty the vein by raising the limb, and then we apply tourniquets. 5 tourniquets are to
What
be
is the first tourniquet you apply? First tourniquet you apply. Where do you apply the first tourniquet?
So first tourniquet near ankle, sir.
Very good. So you start from the angle like
Yes,
it, but when you are getting it away, above downwards you are taking.
Yes, sir. So while opening, we go from above downwards.
So when you are doing the multiple tourniquet test, you have to always open the lowest one first. You know?
Suppose you are elevating the limb and the veins are the
Then
delicate
you
veins
should
are
go
still
up.
there, are not empty. But
Did you do the Fegan test in this patient?
Yes, sir.
But you have not mentioned anywhere the Fegan test.
Prominent on what aspect?
Yes, sir.
What's Fegan test?
Sir, Fegan test is done after emptying the veins. We palpate along the length of the vein if there are any defects in the fascia, and we mark it.
So in this patient, do you expect the
Yes,
Fegan
sir.
test will be positive?
Yes, sir.
So you have to mark the perforators here because there is mainly a perforator incompetence is there. No?
Yes, sir.
Pooja, in Fegan test, as sir asked, you are getting gaps or pits. So these gaps or pits are in the superficial fascia or the deep fascia?
Sir, deep fascia.
Deep fascia.
The gaps in the fascia.
And this is the side where the perforators are.
Enter the deep. Yes, sir.
Just when you are elevating the limb, the veins are not drained out. It is still prominent. What do you will think? What are the possibilities? You are expecting the vein to drain out and guttering of the vein to happen.
Yes, sir.
If it is not happening, what do you suspect?
Sir, patient might have DVT.
DVT, where? Suppose he has a DVT at the anterior posterior tibial vein or anterior vein, will it produce like that? Still it will drain.
Yes, sir.
But only when if the DVT is a proximal, if you have an iliac vein thrombosis or the deep vein in the proximal veins thrombosis, that always indicate a proximal vein. Any other test you do now other than this clinical test? What is ambulatory venous hypertension?
Sir, sir, while walking, our calf pressure increases to up to 200 to 300 millimeter of mercury, which will make which helps, sir, like on walking, which helps it increasing venous return. Sir, if our valves are incompetent, perforators and superficial venous system, sir, while walking, superficial venous system will the pressure will also increase.
So the ambulatory venous hypertension is a measurement of the pressure in the superficial system or deep system?
Sir, superficial system.
So what is the normal pressure in the superficial system?
Sir, on foot, it would be around 100, 80 to 100.
So what determines the pressure there? What is the
Sir,
type of
length of
pressure?
the length of the blood column from heart.
So what will happen? What will happen to the pressure when you are walking?
Sir, on walking, if the veins are competent, superficial veins and perforators are competent, the pressure should reduce as the blood will go into deep venous system and pump to the
Reduce to what? Reduce to how much?
20 mmHg.
So what is now defined? What is ambulatory venous hypertension? You said correctly, but you must put in a way. That's the way. The pressure in the superior venous system, instead of reduction, it will keep high.
It will, yes.
So how will you measure the superficial venous, ambulatory venous hypertension?
So by cannulating the vein and sorry.
You can't ask the patient to walk, but you can do the tiptoe movement.
Yes.
That is equivalent to that tiptoe movement. You will be able to do that.
Would you like to measure in this patient the ABPI?
What is the full form of ABPI, Pooja?
Ankle brachial pressure index.
Any
Did you measure
significance
that?
of ABPI in a patient with a varicose veins?
Sir, if you want to rule out any associated arterial diseases,
One
we
is
can
the
measure
associated
ABPI.
arterial disease may be there. Anything else?
Do you know about arterial diseases in a varicose vein?
Sir, I haven't. Sir, I haven't seen any coexisting arterial and venous disease in a patient yet.
Any other reason you want to measure the ABPI? From the treatment point of view of the varicose veins?
No idea, sir.
Anything you will avoid? Suppose the ABPI is low. You measured and ABPI is low. Anything you will avoid?
So compression stockings, compression bandage, the pressure of the compression bandage to be applied.
Use the low pressure and low pressure compression bandage. If the ABPI is, you find it is low.
Yes.
So that is the most important thing to check for the ABPI. Okay. Okay. Can you go to the next slide now?
Yes, sir.
Why did you examine the abdomen of this patient?
So to look for any palpable organomegaly in pelvis or in abdomen, as it might be pressing on the iliac veins, and which would be one of the reasons causing varicosities in the lower limb.
Organomegaly or lump?
Lump, sorry, sir, lump.
Where? Lump where?
Sir, in pelvis, if there is any.
The lower abdomen and the pelvis.
Yes.
Okay. What is the commonest cause of varicose veins?
Sir, primary, sir, weakness of valves on vein wall.
Sir asked, what is the commonest cause of the varicose vein?
In terms of the abdominal lump, when you are saying, what is the commonest cause for the varicose veins?
We have
More
only
common
two major
female.
types now. Obstructive, restrictive. And what is the type?
Sir, if any
commonest compression of veins
in the females.
Physiology.
ovarian mass.
No.
Physiological.
How many? Physiological. Female patient, pelvic mass or pelvic pelvic
compression. Let me take.
What is the large size pelvic swelling that occurs in females? Very large size pelvic.
Pregnancy is the most common.
Pregnancy.
Doesn't matter.
Yes.
No, is it the pregnancy will cause only obstructive varicose vein? Any other varicose vein it can produce?
what are the hormones? What are the hormonal levels that are there in pregnancy which can have some effect on the veins?
Sir, increased progesterone, sir, increases the risk of thromboembolic events. And sir,
Venous dilatation. Okay. So this patient has no other features other than the
dilated vein.
only the no cutaneous changes. Just he has a very large.
Yes, sir.
Other limb is totally normal. No evidence.
Yes, sir. No evidence of any abnormality in the other limb.
Where else you can get a varicose vein?
Sir, in spermatic vessels, in esophagus.
You must be a little more fast, no, saying this, because every in between, if you are taking so much time.
Yes, sorry, sir.
That shows your confused mind. Answer it. If you know, say don't know. Yeah, right. If you say esophagus, always you have to say the other end.
Yes, sir. In rectal, sir, hemorrhoidal veins.
Oh, okay.
Yes. So hemorrhoid is also a type of varicosity, you know.
Yes, sir.
What is the definition of varicose vein?
Sir, elongated, dilated, tortuous vein, superficial vein in the body.
Yes, there have to be three components.
Sorry, sir.
There have to be three components in the vein: elongation, dilatation, and tortuosity. Okay.
Tortuous. Yes, sir.
And what is the most important thing with this vein? With if just a dilatation, just a tortuous vein, we will not call this a varicose vein. And
Yes,
only when it shows demonstrable reflux. There must be reflux of the blood flow.
Yes, sir.
Then only that is the significant point to say it is a varicose vein.
Yes, sir.
So you have done a clinical examinations, other things, and what is the your diagnosis you are going to make?
Sir, in diagnosis, sir, for left lower limb varicose vein involving great saphenous vein and multiple incompetent perforators.
Which is the major problem in this particular patient? Is the great saphenous vein a problem or perforators are the problem?
Sir, great saphenous vein.
Is more important problem.
Great saphenous vein, sir.
Yes, why?
Sir, because of
suppose if the perforators was a main problem, then you would have seen certain things because in the limb. Hello, okay, am I audible to you?
yes, sir. Yes, sir.
Yeah. You would have seen some discoloration, blackish discoloration. You should have seen more local issues. No? If the perforator competence was more of a problem than the great saphenous veins. Yes.
Yes, sir.
So what treatment would you?
Yeah. So we'll ask for the grade. How will you CAP grading?
Sir, CAP grading of this patient would be C2, EP, ASP, and PR. Sir, C2 varicose vein, sir, E primary etiology, sir, in anatomy, superficial and perforators. So
what is C2R? What is C2R?
Sir, C2R is reflux, varicose vein with associated with.
No. That will come as a separate etiology you are going to write.
Recurrent.
What is C4C?
C4C is corona phlebitica.
These are the changes in the latest 2020. The CAP, this two is added to that.
Yes, sir.
So you put this the primary or second?
Sir, primary.
Primary.
Yes, sir.
Why?
Sir, because
what do you want to say it is a primary?
Sir, because there must be weakness of vein wall and perforator valves. Sir, because no obstruction, no secondary cause could be identified in this patient.
No, invariably, the commonest secondary cause is only a DVT.
Yes.
The patient should develop. And when the patient is having such a huge vein with the perforators incompetence, but the points in favor of not to think of secondaries, there is no obvious evidence of any deep vein involvement. Like cutaneous changes, skin changes, any dermatitis, if it is there, then definitely would have thought it's a secondary cause. But in this case, since there is no involvement of the cutaneous involvement, more likely you can put as a right. And what is the mechanism in the DVT? Where do you get a varicose vein?
Sir, I cannot
If
understand.
patient is having DVT, what is the mechanism of development of this varicose vein? That is the question, sir.
Sir, if DVT is present, superficial veins won't be able to drain into deep veins during exercise or vigorous activity. So, sir, due to back pressure changes.
At what process of DVT, pathophysiology, in what process it will lead to varicosity? Just think beyond the illness only.
Only when it is a reflux, you will get a varicosity. When the deep vein is fully thrombosed, you will not get any reflux.
So in which process you will get this?
Sir, when the muscle demand increases,
what happens when DVT resolves?
It is a time-taking process. Now, multiple hints have been given to you. The process, DVT has been taken place. Now, patient is developing varicose vein in the superficial vein after certain time. Now, the process, one obstruction process is there, already taken place. Now, what is the process?
Something.
Recanalization.
Recanalization, yes. That leads to damage of the
You
valve.
have too many hints for every question, I suppose.
Sir, just beginning of second year. Just beginning of second year.
Even when the vein is too much dilated with the blood or stasis, the normal valve itself cannot approximate normally. When the walls in between, though there is walls are normal, walls are not damaged even, but the veins are very much dilated, that physiological approximation of the veins will not be able to happen. So that itself can cause. Then the process of destruction of the wall and either recanalization and the thrombolysis which is taking place, all that will be lead on to that. Many times DVT will go unnoticed. But even after the patient is having the varicosity, we will come and do that. So how you want to proceed? How you?
Sir, various treatment options are available for this patient.
How do you proceed? How do you proceed?
Sir, diagnostic
treatment.
No, sir. Diagnostic workup is done of the patient. Sir, blood work was all within the normal range, and sir, ultrasonography, abdomen, pelvis, and KB was done, which was.
Pooja, I'm sorry to interrupt you. Would you like to jump directly for the blood investigation unless your diagnosis is confirmed? You have to first confirm the diagnosis, then further treatment will be required.
This is one statement we are making in all our PG clinics. The first thing is confirmation. Then only all other things comes into that.
Sir, Doppler, left lower limb venous Doppler was done in this patient.
What Doppler?
Sir, I couldn't hear you.
What you are expecting in the Doppler? What are the things
Sir,
you look in the Doppler for the varicose vein?
Sir, incompetence of SFJ we would be expecting, and sir, dilated tortuous vein.
What do you mean by Doppler has no word called incompetence? What you have?
Reversal of flow, sir, on Valsalva.
What is it? When you say it is a significant reversal of the flow? There is always inflow and the external flow will be there. Even whatever the normal flow, there will be reflux will be there.
Yes, sir. Sir, for
will
more
you
than
do a
one,
Doppler? Will you do ultrasound or you will do
Not
something
gone
else?
into that. And what are the
sir, duplex scanning.
Yeah, say duplex, no?
Duplex
Do
scanning.
not use the word separately USG and the venous Doppler.
any augmentation?
Okay, yeah, say you will do a duplex scan, no?
I'll do a duplex scan, sir.
Yeah. Right. So when do you say the saphenofemoral incompetence is there?
Sir, when there is a reversal of blood flow, sir, for more than 1 second.
1 second.
1 second.
It's too less.
3.
Is 500 milliseconds, no? If it is more than reversal of flow is more than 500 milliseconds is there, or 0.5 seconds, which is there.
0.5.
Okay. If it is more than 1 second, it is the grade 4 reflux is there. If it is more than 0.5 is there, that is the saphenofemoral incompetence is there. And there has to be reversal of the flow has to be there. That you can demonstrate with the Valsalva maneuver.
Yes, sir.
And how do you say the perforator is incompetent?
Sir,
How do you say the perforator is incompetent?
Sir, clinically, from clinical tests.
No, on duplex.
No, the same.
We are talking the
duplex and
duplex.
Sir, on squeezing the calf or
No, to say the perforator is incompetent, you have to add one thing more. Apart from the reflux which is there, which may be 0.3 to 0.5 seconds, but you have to measure the diameter of the deep fascia defect. If it is more than 3.5 is there, or 3 millimeter is there, then that is added with that. So both the things makes the diagnosis of the incompetent perforator. Where do you measure the GSV? What is the common site for measurement of the GSV?
sir, it's saffron.
No, GSV starts from angle to thigh, no?
Yes,
And
sir.
where do you measure? For to say it must be more than what to say varicose vein, it must be what is the size?
Sir, more than 3 mm. In
So
diameter.
where do you measure?
Sir, mid thigh.
Mid thigh is right. No? You should measure it at the mid thigh level. Right. Okay.
It's called
Now, if you to
Egyptian, I
see
think so.
one thing on the duplex scan, what that thing you want to see? I ask you just see for one thing. What you are going to see?
Some sign.
Mm.
You see a lot of comics in the TV.
Mickey Mouse sign.
What does it mean?
You will like to see
Components
the deep vein thrombosis. Huh?
Yes.
Okay, that is the most important thing which you have to see because your management will change according to that.
Yes.
Okay, so that is the most important. And then you can see Mickey Mouse sign and all other signs which are there. Egyptian eye sign which is there, Mickey Mouse sign is there. That all you can see. You know? Okay. Any other investigation you want to do?
So duplex scanning and then otherwise, sir, venography, but we do not.
In which case you will do the venography?
Yes.
When you will do a venography?
Sir, when we are expecting deep venous system to be involved.
Yes. When you're expecting the deep venous system or it's a recurrent type of the veins which are there. You have done the surgery or whatever the treatment has been done and there's a recurrence of the veins is there, then you should always check for the deep venous system. What is IVUS? IVUS?
Sir, I don't know.
Intravascular ultrasound. Okay, intravascular ultrasound again for the deep veins. Okay, if there's any problem, the deep veins is there, then in that case you can do the IVUS also there. No? Okay. But for the superficial system, duplex scan is enough. No other further investigations are required for that.
What does it included in the duplex scan?
So Doppler ultrasound and B mode imaging. B mode ultrasound imaging and Doppler is
What do you mean by
included.
B mode?
Sir, it will
No, what stands for B? B stands for what?
beta.
Not beta. So A scan is amplitude scan. B is a brightness mode.
Right.
Yes, sir.
What is the difference between Doppler and ultrasound?
So Doppler shows arteriovenous flow extent
I'm
and
not asking what you show. Ultrasound show kidney, ultrasound shows the spleen. We are not asking that. By principle, what is the difference between ultrasound examination and Doppler examination? It's a Doppler principle. What is the basic difference when you say it is an ultrasound, when you are saying it is a, and you are combining, and each one does one particular function on what? So in an ultrasound, the sound waves are reflected by the static object. Doppler, the sound waves are reflected by the moving object. So when you are combining both, you are able to get both. You are getting the static object like the arterial wall and things you will be able to see. And what is the sensitivity and specificity of the duplex equivalent MRI, MR angiogram, or is it or CT angiogram? Is it sensitive enough? It's almost 80 to 85% equal sensitivity. When you do properly a duplex, and it is almost equivalent to the direct investigation which you are doing on that.
Pooja, what is that moving object by which the Doppler waves they are reflected? What is the moving object there?
transducer.
What is
No,
the
Dr.
moving
Raj just
object?
said, na, the moving object is there.
What things moves and which you notice on scan? What things move?
Sir, blood.
Only one thing is there.
Yeah, yeah.
Dr. Only one thing is moving.
Blood, sir.
What is there in the blood?
What component of the blood is reflecting the sound wave?
Sir, blood cells normally.
Which blood cells?
RBCs.
RBCs, no? And what is there in the RBCs?
Sir, hemoglobin.
Hemoglobin. And what is there in the hemoglobin?
One object.
Iron.
One object.
Yeah, iron is there, yeah. So in
Iron
fact,
is there.
it is reflected on the iron which is there in the RBCs, jo hai, na? Which is reflected. Jo hai. Okay.
What is that blue and red
do you
thing
say
that
it is
you are getting in the Doppler?
Wait.
Sir, blue and red, sir, shows
By
the
Doppler, how will you say it is a vein? How will you say it is an artery?
Sir, in Doppler, we assign blue and red color. Sir, blue color means when blood is going towards the heart, and red means when it is going away from the heart.
No, but using a Doppler probe, and how will you say it is a vein? How will you an artery? Not looking at the blue and black. What is the principle saying? Suppose the RBC is coming towards you. What is it?
So deoxygenated and oxygenated.
Towards your probe. If it is coming towards your probe, it is an artery.
It is.
The color of the artery can be changed to blue if you reverse your probe, right? So
Yes.
it is not color dependent. It is the flow dependent, whether it is coming towards you or going away from the probe. That is how it is noticed.
Yes, sir.
What is plethysmography?
Do you
You are
know?
aware of?
If you know, it's okay. Otherwise, I don't know.
No, sir, I don't know.
It is not.
I don't know. Should be very loud. I don't know.
I
Should be
don't
very
know,
loud.
It is a change in the volume and the time taken to the volume to refill. Suppose if you are seeing when you are walking, when the muscle is contracting, the blood is pumped up. So this vessel will be empty. So the next cycle, it takes time for the refill of that vessel, the volume, the refilling of that area, the blood. But if there is incompetence, it will immediately fill. So by using plethysmography, you assess the time taken for refill of the veins. And that will be able to help you, and if there is any incompetence in the walls are there.
Okay, sir.
It's a volume measurement. So you are done, all the test is done, everything is normal. Now only the patient is having such a huge dilated tortuous vein. And what options you have in the management?
Sir, in this patient, the management options either can be, sir, we can do SFJ ligation along with the stripping of great saphenous vein and perforator along with perforator ligation, or sir, radio frequency ablation, and sir, radio frequency ablation can also be done in this patient.
It's a relatively large vein, no? Really, what is the size of the vein, dilated vein? The size, you have measured the size because the picture looks like it's quite a large vein.
Yes, sir.
Then what is the size you have measured or not?
Sir, I have not measured the size of the vein.
Okay. So if it is what up to what level, beyond what level you will not be able to do RFA? What is the contraindication for RFA?
And why?
Sir, beyond mid calf level, distal to mid calf level, we won't be able to do.
No. You can go up to the
Diameter.
size of the vein. It's up to 1.2 to 1.3 centimeter will be justified. And if it is going beyond 1.5 centimeter and your probe when you are doing it, the approximation is not possible. You will not be able to do it properly. So if the vein is so much dilated,
yes,
and radiofrequency ablation may not be an ideal choice.
But then
And there are
ablation can be done in this patient.
And there are multiple bunches of dilated tortuous vessels around the calf at the anteromedial aspect. So that also will not be probably able to treat with this ablation therapy. You might have to do deworming.
What are the ablative methods you know for this?
Sir, endovenous laser ablation can be done using wavelength around 1750 hertz. Sir, using intumescent anesthesia in this patient.
What do you mean by intumescent anesthesia?
Sir, anesthetic drugs are given perivenous.
Anesthetic drugs?
Sir, lidocaine and NS is infiltrated perivenous in perivenous region.
Postgraduates, as you will always expected to, what is the level, how much you are going to give? How do you prepare the intumescent fluid? Anything else other than lidocaine and the in your normal saline, you'll add anything more?
Sir, xylocaine and NS.
What do you want to give intumescent?
Sir, it is well localized and it will help separate vein from other nearby structures.
Where do you want to separate?
Other nerves and arteries, sir.
No.
No.
No. Which complication you want to prevent by keeping fluid between? See, these are subcutaneous veins.
If the nerve is damaged, you are not going to be worried much. But something else is banned or something else is hidden, you will be worried. And if the patient will
sue you, yeah. He has come for cosmesis and you are already damaging it.
Sir.
This is the heat energy into that. No? So if they are not protecting, the skin will be get damaged. That's the one reason. Any other reason also for intumescent to be used? So you are using a small probe inside that vein, large vein.
Yes,
so when you are using a intumescent, it will produce a compression effect on the vein. So approximation of the vein and the probe which you are using will be much more.
Yes, sir.
Do you have any non-intumescent? Sir, go ahead, sir.
How do you see that your tumescent fluid is infiltrated properly on your probe visualization? What is that known as?
Sir, halo.
What is that known? Saphenous eye. You just see like an eyeball and sclera, right? Because it is given in the between the venous wall and fascia. There will be fluid around the
Vein.
venous lumen, which will be look like eyeball.
Yes, sir.
Yes, sir. Jalal, sir, you were asking something.
Do you know any non-tumescent ablation? There is some ablation technique where you need not use a tumescent. What is MOCA?
So foam sclerotherapy.
So you can have a chemical ablation, you can have a mechanical ablation, or combination of both mechanical chemical ablation. So those ablation where you are using chemical or mechanical will not use a tumescent fluid.
Yes, sir.
Either you are using an RFA or endovenous laser where there is a heat energy is used, or when then only the possible tumescent is needed for.
Yes.
What is HIFU?
Then you can use the glue also, as a non-tumescent. Okay, glue can be used. Like a cyanoacrylate glue is there.
Yes,
That can be non-tumescent.
Yes, sir.
There's only a difference in sclerotherapy. We start at the site where injecting, then go upward. Here you go nearer to the saphenophumeral junction, and from there you inject the glue, glue, and you have to slowly come down. It become a polymerization and block them. What is an absolute contraindication for dye injection?
For?
Sorry, this sclerotherapy, absolute contraindication.
Sorry, DVD.
If the patient has a foramen ovale deficient, the opening, the heart, if he has a foramen ovale deficiency, then that is one area, because there is a possibility if it goes, the embolic manifestation will be very severe. Second is only your absolute relative contraindication is all that your allergic reaction, the skin involvement, larger size, all that for the any special method for the sclerotherapy?
Sir, for tesserae, sir.
What is that method?
Sir, we use sclerosant and mix it with air in 1:3 or 1:4 proportion, and a 3-way is used. So to and fro movement is used. One syringe is filled with air and the other syringe is filled with sclerosant. Using a 3-way to and fro movement is used to create the foam. In 1 or 2 minutes, it has to be injected in the affected vein. So at a particular site, 1 or 2 ml. And
so all these ablative techniques are not being done. Patient wants a surgery. When you are doing a Trendelenburg surgery, what are the areas? What is the important things you will follow? Or the important steps in the Trendelenburg surgery?
Sir, in Trendelenburg surgery, sir, we'll first, sir, SFJ ligation in the patient. It has to be.
The first is SFJ ligation.
Sir, we'll first
SFJ ligation. Dr. Pooja, it is SFJ ligation only, or it should be flush ligation? Is there any difference?
Sorry, sir. It has to be flush ligation. And sir, before that, tributaries are ligated.
What is the meaning of flush ligation? How it differs from the ligation only? What is the meaning of flush ligation?
Sir, it has to be nearer to the
Flush means flush.
So it has to be, yes, sir, nearer to the vein.
Nearer to the vein. We are all only doing the surgeries in the vein only. So nearer to which?
Which structure?
They are all together in the vein only, or over the vein only.
Sir, nearer to.
What is
What do we dissect? You have seen the surgery itself.
The tributaries are
No. Tributaries you have ligated. Now SFJ, what did we dissect?
common femoral vein. Sir,
So
where it
you
joins the
ligated plus to the
common femoral vein, sir.
What is common femoral vein? How it is formed?
Sir, popliteal vein continues as
Common femoral vein. So you have to study your anatomy.
Yes, sir.
It's not common. Is there a vein called superficial femoral vein? Is it a superficial vein or deep vein?
Sir, deep. The superficial femoral vein.
Is a superficial vein or a deep vein?
Sir, popliteal vein joins
Go and
superficial
read
femoral
that
vein
and
and forms common.
how it is formed, superficial femoral vein, deep femoral vein, that form the common femoral vein. So that anatomy must be very clear. Okay.
Yes, sir.
So you are done, and will you do the stripping?
Yes, sir.
Up to where?
Sir, up to mid calf level.
Why not up to the ankle? It is a large vein. No, why not up to the ankle?
Sir, distal to mid calf, it is very near to saphenous nerve. So the chances
So what
of
will happen
injury,
if you damage saphenous nerve? What will happen?
sir, loss of
Normally, you take sural nerve for a transposition. Graft you take, saphenous nerve you can take. Is it because of the fear? Surgeon should never see that I am operating near an aorta, I am operating near a vein, IVC we are operating. We will never say, in the fear of injury to IVC, I will not do the radical dissection.
sir, it will result in loss of sensation.
It will not result in loss of sensation. Most often it will not. You said earlier, what is that? What is the purpose of doing stripping? You already ligated saphenofemoral junction. You are ligated the lower. Why do you want to strip? By doing stripping, what you are going to achieve?
So recurrence will be prevented.
No, how? What is the?
Sir, complications. Complications.
No. What is the intention of that? You are already ligated the saphenofemoral junction. No. Then why do you want to strip? You want to strip because the communicating veins, the perforators veins, all that is from the vein to here it is going. So that also you are going to avulse. In the below knee, the perforators are not communicating with the saphenous vein and the deep vein. It is from the posterior arch vein. You are not going to ligate. The post-COVID traumatic events where we want to in situ or where the bypass graft when you do. You want to preserve the saphenous vein, you don't want to damage. So your purpose is not serving, and also there is a need for the saphenous vein to preserve. That is the main intention of doing, not
Sir, you are not audible.
Sir?
Sir, you're muted.
What are the various ways to tackle the perforators?
Sir, perforators or subfacial ligation can be done. Sir, subfacial
What
ligation.
other ways?
Sir, foam, so sclerotherapy, and
Yes. You know any minimal invasive technique which was used for the perforators?
endoscopic facial ligation of perforators.
What is that called as? SEPS. SEPS. What is SEPS? Subfacial endoscopic perforator surgery.
Yes.
Okay, but this is the one technique, all the minimal access technique has always progressed, but this has been regressed. So nowadays, nobody does the SEPs because there are many complications associated with that. Okay. So you can tackle the perforators by the open technique. You can do the laser for that. You can do the RFA for that. You can do the sclerotherapy for that. And also minimal invasive technique, which is there. If there's a deep vein reflux is there, what can you do?
Sort of deep vein system is involved.
You can do the various type of the bypasses there. Veno-venous bypasses can be done.
Yes, sir.
Or you can do the wall surgery. Wall repair can be done. Or
Yes, sir.
wall replacements are there. You can replace the wall.
Yes, sir.
Okay.
Or palmar operation.
Yes.
Dr. Pooja, what different sclerosing agent you can use for sclerotherapy?
Sodium tetrahydrocal sulfate, polidocanol, so 3% or 10% NaCl, and that's it.
There are several agents which are there which can be used for that. You can use the sodium tetrahydrocal sulfate.
That's a
Use the
polidocanol.
polidocanol. You can use the ethoxyclerol. You can use the simple hypertonic glucose can be used. Boiling water can be used. All these are the various other types of the sclerosing which can be used. Pooja, what did you say? What is the power of the laser which is used? You said something 750 or something like that, isn't it?
Sir, 1750 hertz.
No, there's
That's
nothing like
not there.
1750. No? There is no
Not
machine
yet
like
invented.
1750. Yeah.
Not yet invented. Either low or high power. What is are there? But 17.
It started with the 980. Jo hai, no?
Okay, sir.
Okay, initial machines were 980. Then came the 1470. And now the latest one is the 1940. Jo hai.
1940.
Okay, that is the latest one which is there. But majority of the time it is the 1470 which is used for the EVLT.
What
when
is
you
this 1940 or 1470? What is the cream? Do you have any idea?
No,
If
sir.
you don't know, that's
No, sir.
okay.
when you are doing the EVLT, do you ablate right at the saphenofemoral junction or do you, up to what level you ablate that? When you're doing the laser or the radio frequency ablation, up to what level?
The surgery you said flush ligation. Can you also do the flush up to the saphenofemoral junction? You can go.
No, sir. In laser, in endovenous laser ablation, sir, it has to be 1 to 2 centimeter below.
At least 2 centimeter below the saphenofemoral junction.
2 centimeter.
And when you're using a glue for that, it is 5 centimeters. Okay, when you're doing the non-tumescent glue is used, it is 5 centimeter from.
Yes.
Because the glue goes into the deep veins, there is no way out. The patient will definitely have the deep vein thrombosis.
Yes.
You know what is E-hit?
No, sir.
E-hit is endovenous heat-induced thrombosis. So if you go very close to the saphenofemoral junction, there is a chance of the patient will have the thrombosis of the deep veins may be there.
Okay.
And that is why you do not keep these things near the saphenofemoral junction. You keep it away from that.
What is HIFU?
High intensity focused ultrasound, sir.
These are the recent innovations. So this is very broad topic, and the various new, apart from the conventional surgeries, various procedures have been developed. Like sir also already said, the endovenous laser ablation, radio frequency ablation, MOCA is there, some tumescent anesthesia, some without tumescent anesthesia, some cold procedure, some hot procedures. So high intensity focused sonography is there. So it's a very interesting topic. I think you should please go and read the EVLT, endovenous laser therapy, because what is 1470, what is 1940, 70, whatever it is 980. What does it mean? Where actually this acts. So the mechanism you should know, and wish you all the very best.
I will, sir. You have closed that?
Yes, sir. I think we have discussed and we have come to 10th. So I think we should appreciate Pooja being a second year girl, and she was able to take up the questions from all the senior examiners here. And it shows the level of training Dr. Andaresa's unit is imparting on the postgraduates. Sartoskar sir, would you like to give your closing comments?
No, it was a very lively and nice session. A lot of points were discussed. And let me frankly admit, I also could pick up some new points.
Of course, sir, always.
So thanks for those new points. So discussions were much beyond the textbooks, and they were bordered by personal experiences also. So it was really nice to, have clear ideas of what is the clinical situation, what to do, what not to do. I would say textbook is one thing, but this was more of a application, analysis and application of the textbook knowledge. So this was laced by even the personal experiences, and it brought out the application very nicely. And we must all thank Dr. Kanagwal for arranging such sessions. And let's clap for Dr. Kanagwal. He has come to our GS Medical College also, and though he was silent today, I know
he is always silent, sir.
Knowledge he possesses.
Yeah, unless the things go beyond certain limitation, he is silent. And,
Yeah,
sir, Kanagwal sir is the our discovery of COVID. COVID. I always thank COVID also along with Kanagwal sir. Because of that, the national level of teaching has improved a lot.
Yeah, no, he has come to GS Medical College because
I know, sir. I know, sir.
So there he has been quite. He has been speaking quite a bit over there, so we know. So thank you, sir. Thank you for inviting me. Thank you for this very nice session with full of knowledge, lot of thought-provoking discussions. Thank you so much. And it's quite late, so everybody's family is waiting, as is mine also,
Sir, wish you could join us whenever possible. God's grace has been happening now. Close to 186 sessions have gone in the last 3 years. And
sure, it will be my pleasure.
It falls in place, and seniors like you always help us by spending your valuable time with us. And I wish it goes on and on as much as possible. And I'm happy to hear when students come back to us to tell that, sir, it was useful. We passed the exams like that. So that is what is one thing which keeps us going, sir. Thank you for joining today. Pooja, do you have any questions? You have been answering very well. So I'm sure you have been studying hard for the last couple of weeks once Sir Andare sir allotted you this case. Do you have any questions or doubts, your thoughts you would like to share?
No, sir.
Okay. Good luck to you. Faculty, Kanna sir, please. Yes, sir.
No, we just had a query in the last case about the neurofibromatosis, isn't?
Yes, sir.
Yes, sir.
So I just went to the literature there.
Yes,
and
sir.
Found that FDG scan will be picked up by the neurofibromas also.
Yes, sir.
But to differentiate whether they're the benign or the malignant one, it is the SUV max which is there. You measure that SUV for that. And if it is low SUV is there, it is the benign one. If it is the high SUV is there, it will be the malignant one. So that is why, the place of the PET scan in a case like this, it will be really doubtful whether we should carry out or not.
Yes, sir.
I think I wish. Yes, sir.
For soft tissue sarcoma, the role of FDG is only to differentiate the high grade and the low grade. But the new thing the sir told, I was not aware of this thing. Thank you so much, sir, because I was not aware whether neurofibromatous lesion is taking up FDG or not. That's a good thing. But for soft tissue sarcoma, Pooja and Joy, this is to differentiate between the high grade and the low grade. This is not for the diagnosis. This is for the grading only.
Yes, sir.
Probably with the advent of newer radiopharmaceutical, I think there may be actually every tissue like hormone-based tissues, receptor-based tissues. I think in another 2-3 years, we are going to have a gamut of traces, tissue-specific traces. Now, already the PSMA scan for prostate is taken up in a big way because that is specifically doing the prostate malignancy workup very easy. And I'm sure every organ, the DOTA has come up and is here to stay for a long time. Same way, I think we are expecting more radiopharmaceutical coming in where these type of specific staging workups are much easier. So thank you, sir. Thank you for that vital input. In fact, you have pasted the group in our PG Clinics faculty group. So I'm reading through that. And George, would you like to have any comments? You've been staying with us long time.
No, sir. Thank you, sir.
Thank you very much. So, faculty, with your permission, can we call a close? Karnakaran, sir?
Yes, sir.
Good night and goodbye.
Good night, sir. Good night, sir. Thank you very much, sir. Thank you very much.
Thank you.